Good afternoon, and welcome to the Partners Against Mortality and Epilepsy annual meeting, which is appropriately titled, Even a Pandemic Can't Stop the Quest. My name is Tom Stanton. I serve as the executive director of a Chicago-based nonprofit called the Danny Did Foundation, and I have the privilege to kick off an exciting and informative session. Next slide. Although the PAME Collaborative dates back to 2012, this year is our first opportunity to present PAME as a session within the American Epilepsy Society meeting. We are thrilled to have more than 150 guests registered to watch, which includes families, providers, researchers, and advocates. Next slide. I entered into the world of epilepsy when my nephew Danny began having seizures at the age of 2. Our little Tuffy, as his grandma called him, had his seizures mostly controlled by medication. 2.5 years later, though, after his 5th known seizure, Danny died suddenly in his sleep. The term SUDEP was first revealed to his parents when they saw his death certificate. With that experience as my motivation, I've been proud to partner with Gardner Lapham in representing the family perspective on the PAME Executive Committee. Gardner and I are joined on that committee by Dr. Elizabeth Donner, Dr. Jeff Buckhalter, and Dr. George Richerson. We want to give our heartfelt thanks to every provider, researcher, and healthcare professional who has decided to join this fight against mortality and epilepsy. We all share an urgent desire for progress, and that is one of the many traits that makes the PAME initiative special. Partners Against Mortality and Epilepsy began as a first of its kind collaboration among healthcare providers, clinical researchers, basic scientists, public health officials, patient advocates, caregivers and bereaved families, and people living with epilepsy. These stakeholders came together with a common goal of better understanding and working to prevent epilepsy-related forms of mortality, including suicide, accidents, status epilepticus, and with a strong focus on sudden unexpected death in epilepsy. In 2012, since 2012, PAME has convened 4 powerful international meetings that have advanced research, education, and clinical care, while supporting and learning from affected families. On this slide, you can see the full agenda we have for our 2-hour session. We have developed a tradition at PAME to begin our meetings with remarks from a family. After all, for all the work in research, advocacy, and education that is related to the risk of mortality and epilepsy, it is the story of families that we are trying to change. It is a desire to alter the outcome for our kids, our patients, and our loved ones that is the driving force behind the work of everyone listening today. Next slide. To that end, we will start our session with words from Libby and Victor Boyce, who, as most of you know, lost their talented and loving son, Cameron, to SUDEP last summer at the age of 20. For millions of Americans, the aftermath of his death was their first introduction to the term SUDEP. After hearing from the Boyce family, you will see and hear from Dr. Jeff Buckhalter, who will moderate our Q&A segments throughout today's session. Next slide. PAME has always been conceived, planned, and coordinated by volunteers from a diverse group of professional, nonprofit, and government organizations. In fact, the essence of PAME is its focus on inclusion and the belief that we will make more progress by working together. In this spirit of collaboration, many people have teamed to bring our program to you today. Special thanks to Eileen Murray, Ann Gramiak, and the staff at AES for their meeting coordination, and for PAME with a session within their annual meeting. Sincere thanks also to the 4 advocacy organizations who have sponsored this session: the Dravet Syndrome Foundation, the National Association of Epilepsy Centers, the Child Neurology Foundation, and Jenna Robinson Charities. Looking to the future, PAME is set to increase the frequency of its educational content, which will include a series of webinars that will occur throughout 2021. Stay tuned for more information coming later today about that. Next slide. I hope you all find today's session useful and inspiring. If you are moved to become more involved with PAME, we welcome you. And now, please give your attention to remarks from Libby and Victor Boyce.
Hello, I'm Victor. This is Libby. We're the Boyces. We are Cameron Boyce's parents. And we're honored to be here today to speak with you guys. But we're also deeply saddened to be here because our son, Cameron, died of SUDEP, which is sudden, unexpected death in epilepsy. He passed away on July 6, 2019, a couple of days after the 4th of July. Obviously, that was the worst day of our lives. We were blindsided by it. Cameron was first diagnosed with epilepsy when he was 16 years old. He had only had a total of 5 seizures from the time he was diagnosed to the time he passed away. All of the seizures he had were in his sleep. So it was something that was confusing and hard to deal with because he had so few seizures. It was difficult for us and the doctors to get a handle on his medication. We would know when he would have a seizure, not because he would tell us, but because he would wake up, he would have bitten his mouth, he would have bitten his tongue, he would have a raging headache, and that was the indicator that he had suffered a seizure. And like I said, he had only had 5 total until the last one that took his life. One of the things that was difficult for us was we didn't really get a lot of information from our healthcare provider about how to handle his epilepsy. They did give us like a little brochure and gave us basic information, but we had never heard of SUDEP until he passed away, and the coroner told us that. And so when he died, we were completely blindsided and devastated because we didn't know that his epilepsy could be fatal. And so our thing now is, we don't want anybody to suffer the same fate that we did, as far as being, frankly, ignorant to the possibilities of what could happen when you have epilepsy. And so we started the Cameron Boyce Foundation to raise awareness, to raise money for research, and our goal ultimately is to end epilepsy, to cure it, and to especially SUDEP, which is an offshoot of epilepsy. And we've learned so much about epilepsy since our son passed. We found out that 1 in 26 people will develop epilepsy in their lifetime, which is staggering. And the thing that was really concerning and bewildering to us is the fact that it's not talked about. It's not talked about like Parkinson's. It's not talked about like cancer or many other, devastating diseases. But
it's so much more common.
It's actually more common. It's the most common disease that we know the least about. And so that has to change. And so our whole focus is to, like I said, to raise awareness and to raise money for research, but also to use our son's global voice. My son was loved worldwide. And because of that, a lot of people that when he passed, a lot of people that were like kind of hiding or felt disenfranchised or they're in their shadows, they came out and they're like, wow, I have epilepsy too. And people are talking about it more. And so we figured, man, we have a platform here. We should use it to help and to be impactful. And so that's our goal, is to help those people that are living with epilepsy every day and struggling and trying to figure it out, to give them a voice and to get them help and to make sure they're being advocates for themselves with their doctors and their healthcare providers, and to get more scientists and epileptologists and neurologists together to really, really dig deep in this and to find a cure for it, because it's devastating And, we heard every day with the loss of our son. It's just been a nightmare that we don't want anybody else to go through.
And since we're talking to the medical community here, what we want to say is we think you can do better. Obviously, not all of you. I'm sure a lot of you actually really train your new people with the new diagnosis of epilepsy. But we do think that doing more is better. We were not armed. We were not given tools whatsoever, but a brochure. The second seizure that Cameron had is when we got the epilepsy diagnosis. And they sent us home with Keppra, did not share anything about taking the medicine at the same time every day, reducing stress, being on a sleep schedule, like how to eat, anything that it can be fatal, it's a very serious thing. So for us, it was very cavalier, the way we were told, and the follow-up, we weren't even told to come back and see them in any time frame. My husband has said, that when he got a vasectomy, he had more information given to him during that time. They had a class.
I had to take a class. I had to sign things. I had to learn things. It was much more exhaustive and informative than, you're not going to die from a vasectomy, but epilepsy can be fatal. So it's just staggering to think that something so impactful on your life is treated kind of like, kind of blasé. So
also, it's important not to scare your patients, and we understand that wholeheartedly. And I understand that's what we hear, is that you don't want to scare your patients, but I do think they have to be armed with knowledge, and they do need an orientation to this disease. And I just think that's really, really important. If there's one message we could give to the medical community who are giving this diagnosis on the daily basis, is read up on it. Have your patients really get to know the disease, know their triggers, know how to take their medication, know what to look for.
And I would also add, connect them with the epilepsy community. We were never, ever involved. And the epilepsy community is huge. There's lots of organizations out there that are doing great work, but we knew nothing about it. I guess we could have done our own research, but if the provider said, hey, you can talk to these people, for support, for community, it would have been very, very helpful for us, because, like I said, we had no idea the magnitude of the diagnosis, let alone how many people are dealing with it and trying to work with it. And it's just something we strongly feel that there's not enough information. It's kind of in the shadows, and we need to bring it out.
Yes, and also, we are not on an island. We have heard this from many, many families that they were just not given information. So we just highly encourage you to think about how you are giving this diagnosis and the tools that you're giving to your patients, right. Not to freak them out, not to scare them, but to let them know that it is life-changing, and that they need to have tools in their toolbox. And
tools and support.
Tools and support. And we just want you to know that we're not giving up this fight. We are trying to bring epilepsy and SUDEP out of the shadows. We are putting the Cameron Boyce Foundation behind research, behind awareness, and that we really appreciate all the work you do. And we're happy you're participating in this, and we are willing to talk to anybody at the Cameron Boyce Foundation who would rather have a smaller private conversation, but that we bless you for everything you're doing. Yes. We really appreciate it. Yes. And also appreciate you just listening to us and trying to get this message out and building your ability to give your expertise to your patients. Thank you.
Thank you very much.
Hello, I'm Jeff Buckhalter, and as Tom Stanton told you, I'll be helping introduce folks this afternoon. I wanted to thank you all for attending PAME at the AES annual meeting. I think it's safe to say that on behalf of all of us, we'd like to thank the Boyce family for telling their very important, heartbreaking story to us all. We have several very distinguished speakers today. So for purposes of time, I'll refer you to the PAME website for their extensive bibliographies. As we go through, please ask questions in the chat box, and we'll try and get as many answered as we can during this presentation. So for starters, please join me in welcoming Dr. Elizabeth Donner for her presentation, Mortality in Epilepsy, Focus on Prevention.
Thank you. It's my pleasure to be here today and to be part of what I consider to be a very important symposium as part of the AES meeting this year. I'm sorry we're not together, but I'm glad we're able to talk about mortality in epilepsy. And I'm going to take the next few minutes to talk to you about mortality in epilepsy with an eventual focus on prevention. These are my disclosures. And really a pretty easy learning objective today, just to be able to identify the factors that contribute to mortality risk in people with epilepsy. So we know that people with epilepsy have an increased rate of death compared to premature death compared to the general public. And that's about 2 to 3 times an increased risk. The standardized mortality ratio for children with epilepsy is actually even higher, reflecting the high mortality among children with significant neurological impairment, as well as the overall low mortality rates among children in general. And a nice recent systematic review of systematic reviews demonstrated that people with epilepsy are more likely to die prematurely from epilepsy-related causes of death. So in this paper, the standardized mortality ratio of the combined studies was 3.8 for epilepsy-related causes, but only 1.7 for non-epilepsy-related causes of death. When we think about epilepsy-related causes of death, Oren Davinsky, Dan Friedman, and others put together a nice classification, which I've placed on this slide, just as a way of kind of trying to categorize these deaths. And we can consider deaths due to epilepsy. That would include things such as sudden unexpected death in epilepsy, status epilepticus, and then accidental deaths due to drowning, motor vehicle accidents, falls, burns, other accidents. There are deaths due to acute symptomatic seizures. Deaths that we consider indirectly due to epilepsy, those would include things like aspiration pneumonia in the context of a seizure, suicide, or iatrogenic deaths due to medication adverse effects, which could include obesity as a side effect of some medications or cardiovascular disorders as a side effect of other medications. And then there's deaths due to the underlying neurological conditions, such as brain tumors, strokes, metabolic, genetic, and neurodegenerative diseases. So with a focus on prevention, I would like to consider unnatural causes of death. And there's a couple nice studies that I'd like to highlight here. Gorton in the UK and Agard in Denmark demonstrated that people with epilepsy are at a significantly higher risk of unnatural death. In the Gorton study, which I'll tell you more about in a bit later, it was found that people with epilepsy had a 5 times greater risk of unintentional medication poisoning and a 3.5 times greater risk of intentional self-poisoning with a medication. Interestingly, even though these are people with epilepsy with presumed access to anti-epileptic drugs, opioids and psychotropic medications were more often the culprit in the intentional self-poisoning than anti-epileptic drugs were. Agard demonstrated that people with epilepsy had a 3.5 times increased risk of accidental death. And in our own population in Ontario, Canada, we found that the drowning risk in people with epilepsy was almost 10 times higher than the general population. I was shocked and disturbed to learn that half of those drownings occurred in the bathtub. Even though we believe we do good education about this, we obviously don't, and that those deaths were actually very rarely associated with intoxication. I want to talk about psychiatric comorbidities in epilepsy. We know these are common, but the study that I just referenced by Gorton really highlighted this. So this was a massive study where they had where they had a cohort of over 50,000 people with epilepsy and compared it to over 1 million people living without epilepsy. It was demonstrated that people with epilepsy were more likely to have 10 of the 11 comorbid neuropsychiatric diagnoses. The only one that was not more common in people with epilepsy was neuropathic pain. They were more likely to have been treated with psychotropic medications and more likely to have recorded a diagnosis of a new mental illness during the follow-up period. 3 times more common to have alcohol, other substance abuse, and schizophrenia. 2 times more common to have bipolar depression, personality disorders, or self-harm disorders, and 1.5 times more likely to have general depression and anxiety. And psychiatric comorbidities increase mortality risk. So in Fazel's Swedish cohort, which again, huge numbers as noted there, it was demonstrated that people with epilepsy had an adjusted odd ratio of 11 compared to both people living without epilepsy and to a control group of unaffected siblings. 15% of those premature deaths in people with epilepsy were from external causes, things such as suicides, accidents, and assaults. And specifically, an odds ratio of 5 for non-vehicle accidents and an odds ratio of over 7 for suicide. Of those people who died from external causes such as suicide, accidents, and assaults, 75% had comorbid psychiatric disorders, depression and substance misuse being the most common. This was also seen in a Danish cohort in which people with epilepsy had a mortality rate 4 times greater than the general population. People with schizophrenia alone had a mortality rate 6 times greater than the general population. But in people with both schizophrenia and epilepsy, the mortality rate was 12 times that of the general population. So not only are psychiatric comorbidities very common in epilepsy, they increase mortality risk. Interestingly, mortality is also increased in people with psychogenic non-epileptic seizures. Very interesting paper published just this year by Nightscales et al. Found a 2.5 times increased rate of mortality compared to the general population in people with a diagnosis of psychogenic non-epileptic seizures. That rate was comparable to that diagnosed with the risk in people with drug-resistant epilepsy. 18% of these deaths were suicides and accidental poisonings compared to 6% of the general population in Australia. All the suicides and accidental poisonings were drug or medication related, and those at greatest risk were those in the under 50 age group, in which case 44% of the deaths were suicides and accidental poisonings. So for a moment, I'd like to consider more closely this focus on prevention. I want to remind you and demonstrate that better epilepsy care saves lives. Briefly, I will tell you that there were 3 really nice papers published in about the last year or so demonstrating this in 3 different countries. In the UK, Hargraves et al. Demonstrated that in adolescents with epilepsy, greater involvement of tertiary specialists in pediatric care is associated with decreased all-cause mortality in the period after transition to adult care. In New Zealand, Hamilton demonstrated that people with epilepsy that was untreated or delayed to be treated had a higher risk of acute myocardial infarction. And in Alberta, Canada, people with epilepsy receiving neurologist or epileptologist care had reduced premature mortality. These are great papers, and I encourage you to review them. So what we need, I'm sure you'll all agree, is a focus on saving lives. And this is a very high level, simple prescription for that. We need to educate people with epilepsy and providers about risk of mortality. We need to recognize and treat comorbidities, especially psychiatric comorbidities, and we need to improve access to specialist level care. Thank you for your attention today.
Thank you, Dr. Donner. I wonder if you could share with everyone what your approach is to talking to patients and families, first encounter after someone has had a generalized tonic-clonic seizure. How do you do it?
Oh, thanks, Dr. Buckhalter. And you and I have had the opportunity to talk about this amongst ourselves before. And I know it's a challenge, and I know that it's something that people, that practitioners find challenging. And so I'm happy actually for the opportunity to tell you a few of the ways I go about it. First of all, I think it's really important to point out that a fear of death related to seizures or the risk of death in people with epilepsy, that's really a lot of times the elephant in the room. I'm really privileged to be a child neurologist. I work with families. And if a parent has witnessed their child have a generalized tonic-clonic seizure, a big convulsion, and they don't ask you if their child could die of it, then I really think they're just too afraid to ask. I really do consider it the elephant in the room. So a lot of times, if a family doesn't ask about the risk of premature mortality related to epilepsy or danger associated with seizures, I actually just out the elephant in the room and I just say, a lot of families worry when they see their child die of a seizure, when they see their child have a seizure, could their child die of a seizure? And that's the way I introduce the topic. And I think I haven't, in a lot of years of doing this, I haven't actually had any families who have refused to engage in the discussion. There's a few other points in care, though, I think, where we have the opportunity to talk about SUDEP risk and general accident risk and mortality risk. So you're right that at the beginning of when a person is first diagnosed with epilepsy, we know from studies, from both qualitative and quantitative research, that that's when families want to learn about it. But they need to hear about it later too, at times when seizures become resistant to treatment, at times of medication dose changes, at times of surgical referral, when kids are moving out of the house. So things like that.
So when you out the elephant in the room,
Yeah.
and you know that the family is stunned, has more questions, but the visit's over, where do you send them? What do you give them in terms of education?
Oh, great question. There's actually a lot of great resources these days. We know families go to the web. In fact, that's my biggest kind of argument for why healthcare practitioners need to speak to people with epilepsy and their caregivers about SUDEP, because we know they go to the web for it. And really, that's not where we want people necessarily getting their information if it hasn't been properly curated. That said, there are some great, well-curated places on the web to look at that, including information through the SUDEP Institute at the Epilepsy Foundation in the US, through Danny Did Foundation as well. And you already heard from Tom earlier today. We have information at SUDEP Aware as well, and there's SUDEP Action in the UK. All these organizations have curated good quality information and also provide peer contacts for people with epilepsy that I think is an important way to get information. The other thing I'll highlight, Jeff, just since we're chatting, is that from my review for the talk that I just gave, that pre-recorded obviously, one of the things that really hits home is that risk of unnatural deaths, accidents, trauma, suicide, drowning, and those are things that we should be able to prevent. And I think those of us that are working with people with epilepsy and their families, we think we're educating them sufficiently to avoid those deaths. And I think it's just obvious that we're not, and we need to do better.
In the minute that we have remaining, could you just follow up on that just a little bit? And how do you get that information? It's just so extensive to families.
We have, that's a good question. And obviously I don't know the answer because we're not doing well enough yet, but I do think that we need to take a multi-pronged approach. So we need to have open conversations. We need to provide materials. We need to direct them to websites, and we need to partner with organizations that support families. But I think we really probably need to listen to patients and families about how they want the information and give it to them so they hear it and take it in.
Thanks very much, Elizabeth.
Thanks,
that was great. So next, we're going to hear from Dr. Daniel Friedman, who's going to talk to us about epilepsy-related mortality risk, another example of health disparity due to socioeconomic status. Dan?
Thank you to the PAME organizers for inviting me to speak today about some research that began around the time of the first PAME conference in 2012. This is my fourth PAME conference, and I definitely missed the opportunity to be in the same room as all my great colleagues, tireless advocates, and inspirational family members, which are all the high points of the prior meetings. Today, I'm going to talk about the impact of social determinants of health on epilepsy-related mortality, and specifically on SUDEP. These are my disclosures. While many people have become acutely aware of how societal, community, and personal circumstances affect health outcomes during the COVID pandemic, as we see reports of how COVID-19 disproportionately affects underserved and under-resourced communities. It took a pandemic to highlight these inequities for acute illnesses, but researchers have been uncovering ways these factors have influenced health outcomes for many chronic diseases for years. Prior studies have shown that specific social determinants of health, such as socioeconomic status, insurance status, immigration status, race, and ethnicity, have all been associated with disparities in epilepsy care, including access to epilepsy specialists, anti-seizure medication prescription and adherence, utilization of epilepsy surgery, and all-cause mortality in patients with epilepsy. In this talk, I'll focus on our recent research on epilepsy-related mortality, and specifically SUDEP, and to see how that is influenced by some social determinants of health. So based on case control population studies, we've identified several modifiable clinical risk factors for SUDEP, including ongoing tonic-clonic seizures, medication non-adherence, and seizure control, and specifically seizure freedom, and the presence of nocturnal supervision appear to be protective against SUDEP. We hypothesize that these factors are influenced by social determinants of health, leading to disparities in SUDEP rates based on these SDHs. So in this study, we sought to examine the impact of the community socioeconomic status, a reasonable proxy for individual socioeconomic status, as well as correlated to other structural factors, such as healthcare access, stress, and community support with SUDEP rates. And in order to estimate population-based SUDEP rates, we identified all SUDEPs that were investigated by medical examiners' offices in 3 large United States medical examiners. The New York City Medical Examiner, State of Maryland Medical Examiner, and San Diego County Medical Examiner. All these offices have professional death investigators and have a strong public health mission, thereby investigating all deaths that occur suddenly, regardless of whether or not there was foul play suspected. So these 3 offices encompass a catchment area of about 17 million people, with an estimated number of prevalent people with epilepsy of 160 to 200,000. We reviewed all deaths at 2 time points, the 2 years between periods of 2009 and 10 and 2014 and 15, and identified all the deaths where epilepsy or seizure was listed as a cause or contributor to death or a comorbid condition in the ME database. We adjudicated the deaths and identified 217 definite or probable or near SUDEPs in 2009 and 10, and 173 in 2014-15. Here's an example of the flow of death and epilepsy adjudication during the 2009 and 10 time period. Once we identified all the SUDEPs, we then estimated the age and US region and income adjusted epilepsy prevalence for each of the zip codes within the ME jurisdiction, and calculated the rate of SUDEP per zip code. Here you can see the distribution of SUDEPs per 1,000 patient years in each of the zip codes in New York City. What's striking about this map for anyone who knows the demographic geography of New York City is that SUDEP rates appear highest in communities with the greatest degree of poverty. And you can see that on these maps, where on the top is the SUDEP rate per zip code map, and on the bottom is the median household income map for each zip code. You can see this for New York City. You can see this for the state of Maryland. And you can see this for San Diego County, where in all situations, the rates of SUDEP are highest in communities that have the greatest amount of poverty. We then sorted the zip codes in each region to quartiles based on median family income, from the lowest to the highest quartile. And then within each quartile, we calculated the region, age, and income adjusted epilepsy prevalence estimate. We then calculated the SUDEP rate in each quartile and compared the highest to lowest quartile in each region for both of the 2 time periods studied. The overall SUDEP incidence adjusted by region is indicated in the black, and you can see that that in both time periods, in 2009-10 and 2014-15, there was a significant difference between the estimated SUDEP incidence in the poorest communities versus the wealthiest communities, comparing the highest income quartile to the lowest income quartile. And looking at individual ME offices here in the colored shapes, you can see that those differences were across all 3 ME offices. What's interesting is that that the overall rate of SUDEP is actually lower in the 2014-15 time period, but the disparities persist. And in 2009-10 time period, the rate ratio was 2.6, and 2014-15, the rate ratio was 3.3. So overall, the SUDEP incidence among residents of the poorest zip codes was 2.6 to 3.3 times that of the residents of the wealthiest zip codes. The difference persisted even when adjusted for the fact that medical examiner-based SUDEP rates are incomplete because of difficulty with case ascertainment. We did this using probabilistic bias analysis. Overall, there was a 36% decline in ME investigated SUDEP between the 2 time periods, but the disparities persisted. There was no difference between the lowest and highest income quartiles decedents in terms of age distribution, sex distribution, comorbidity index, psychiatric comorbidity, or presence or absence of substance abuse. The only difference between the highest and lowest quartile SUDEPs was the fact that a greater proportion of decedents in the lowest income quartile were non-white. We weren't able to identify insurance status in this study, and interestingly, all regions which in this study were part of Medicaid expansion under the Affordable Care Act. So in conclusion, our study suggests that living in poor communities is associated with increased rates of SUDEP, at least when identified through medical examiner's office. Multiple social determinants of health are associated with lower income communities, including worse access to care, less access to medications, less social support, increased stress, environmental factors, and lack of housing stability. All these factors could potentially affect seizure control and could therefore lead to SUDEP. Addressing these issues through awareness and recognition by clinicians and policymakers could reduce SUDEP. So I'd like to acknowledge everybody that helped in this study, and specifically Esma Karlovich, who was a research assistant that did a lot of the heavy lifting for this study, and all the medical examiners that participated and gave access to their cases. And thank you for your attention.
Thanks, Dan. You know, this is really a seminal study in our field, bringing out the increased rates of SUDEP among those who are experiencing social determinants of health, which are not favorable. I wonder if you could just take a step back and, for the audience, sort of describe the methodology and the uncertainties in estimating SUDEP risks from medical examiner reports. And, you know, the Boyces mentioned that the first time they heard about SUDEP was from the coroner. Could you say something about coroners and medical examiners?
So in this study, you know, we identified all the people who died of SUDEP based on coroner and medical examiner reports. You know, just for the audience, medical examiners are typically forensic pathologists, not always, but typically physicians who oversee death investigation, whereas coroners are often political appointees who may or may not have any medical training, who oversee death investigation. In the US is a hodgepodge of systems. The charge of different offices is a little different depending on the type of death investigator there, whether it's a medical examiner or a coroner. Some are interested in really understanding only if there's foul play or not, homicide or suicide versus a natural death, whereas others have a real public health mission and are interested in population based assessments of disease and mortality. And we chose to work with 3 such offices, and their mission is to really assess and investigate every death that occurs in the community or within 24 hours of hospitalization that is unexpected. And what we did here is we looked at all the deaths where the medical examiner's offices found a history of epilepsy or seizures in the case report, and then independently reviewed the cause of death and determined whether or not they fit the criteria for SUDEP. Now, the Boyces had a rare situation where SUDEP was actually written on their death certificate. And in many such cases, what's listed as the cause of death may be epilepsy, maybe seizure, maybe cardiopulmonary arrest, and epilepsy is a contributor to death. And so there's no uniform coding of SUDEP, and it requires review of the medical records available in the ME's office. And we know from studies that Dr. Tomson has done in Sweden and work we've done in San Diego that there's about a 25 to 30%, 35% of the cases of SUDEP are missed when you're just going through those reports.
Thanks. in the just say to everyone, we're getting some great questions in the chat box, and we'll try and get the answers out one way or the other afterwards. In the minute remaining, could you just talk about what kind of policy changes could address these difficulties that you've highlighted in your study? What can we do about it?
So I think one thing would be to actually get better case ascertainment and more standardized reporting of epilepsy-related deaths, so we could monitor the situation and address the systemic and individual risk factors that are associated with epilepsy in our sort of heterogeneous communities, and understand where access to care, where access to epilepsy specialists, access to insurance, and access to medications may play a role and have real public health response to the numbers. And one possibility that you've been advocating is to have a diagnostic code for SUDEP.
Thanks, Dan. Well, many more questions to be answered. Next, we're going to hear from Doctors Torbjörn Tomson and Kristina Simeone, who are going to discuss SUDEP and sleep.
So my task this evening is to discuss why SUDEP is more common at night. These are my disclosures. I hope to convince you that the incidence of SUDEP is increased during nighttime as compared to daytime, and that nocturnal tonic-clonic seizures is a significant risk factor for SUDEP. I will also discuss possible reasons why this is. My starting point, however, is the Mortimer study. This is the mortality in the Epilepsy Monitoring Unit study that has provided us with important information on the pathophysiology of SUDEP. But in addition to that, it is probably the best source for information on circumstances of SUDEP and of timing of SUDEP, since the cases included in Mortimer's were monitored. One finding was that out of 11 monitored SUDEP cases, 9 were found in a prone position at the time of the event. And prone position has been suggested to contribute to the outcome by compromising respiration. But more relevant for us is that 9 of the 11 monitored SUDEP cases occurred during nighttime. There were 5 additional SUDEPs in the EMU that were not monitored at the time of death, but all these 5 cases also occurred at night. Further support for SUDEP as a nighttime event come, for instance, from our own case series from Sweden that you see to the left, where we look at the temporal distribution of SUDEP cases in blue bars. In contrast, you see in red bars, non-SUDEP deaths among people with epilepsy from the same study population, a different pattern. So nighttime in most cases is equivalent to sleeping hours. And to the right, you see a meta-analysis of 880 SUDEP cases and the circadian distribution among these cases. Again, you see that the majority here, 60%, occurred during presumed sleeping hours. So could it be that nocturnal seizures are more harmful and dangerous than seizures taking place during daytime? This case control study from the UK looked at seizure patterns in SUDEP cases to the left and among controls, surviving epilepsy patients to the right. And what you can see is that nocturnal seizure patterns were more common among SUDEP cases compared to among the controls. The odds ratio was 2.6. In our more recent Swedish case control study, we also found indications that nocturnal seizures were a risk factor for SUDEP. However, we found that it depended on the type of seizures. a history of tonic-clonic seizures, be they focal or generalized from onset, was a clear risk factor with a high odds ratio. However, other types of seizures were not associated with an increased risk of SUDEP. Nocturnal tonic-clonic seizures occurring during the last year of observation was an even stronger risk factor for SUDEP in this study. So how can we understand why nocturnal seizures are associated with an increased SUDEP risk? It's possible that circadian rhythms contribute to making such nocturnal seizures more harmful. One possibility would be that the response to changes in blood gas levels during night are different compared to during daytime. It's also possible that sleep specifically make nocturnal seizures more harmful. This will be discussed in more detail in the next talk. What I will discuss a bit are some specific circumstances associated with nocturnal seizures that might facilitate SUDEP. One being a prone position in bed, and another one being that they are likely to be unwitnessed, leading to less chances for early interventions. I come back to our Swedish case series to the left and the meta-analysis I mentioned earlier to the right. Prone position is known to be overrepresented among SUDEP cases in general, but it's even more so when it comes to SUDEP in nighttime or during sleep, as you can see from these two graphs. And the role of prone position we just discussed in the beginning of my talk. For obvious reasons, nocturnal seizures are also more likely to be unwitnessed, and this is shown by data from our Swedish case series, as you can see here. Not sharing bedroom is, of course, making it much more likely that the event is unwitnessed. In the Swedish case control study, we found that persons not sharing bedroom doubled the risk of SUDEP if they belong to the group of patients with active epilepsy with tonic-clonic seizures. This is in contrast with the outcome of this older case control study from the UK, showing that sharing bedroom or having special precautions intensifying nighttime supervision was associated with the significantly reduced risk of SUDEP. Further support for the importance of nocturnal supervision in the prevention of SUDEP or reduction in the SUDEP risk comes from this retrospective study from two different residential care centers for people with epilepsy and intellectual disabilities in the Netherlands. The SUDEP incidence was compared between these two centers. The first center had a more intense nighttime supervision, shown with the blue bars in the graph. The second center had less of nighttime supervision, the orange bars in the graph. Interestingly, the SUDEP incidence in the first center with a more intense nighttime supervision was 2.2 per 1,000 patient years, significantly lower than in the other center where the incidence was 6.1 per patient years. So nighttime supervision is important, and it's probably important because it facilitates timely and early intervention to prevent the involvement to a full SUDEP. I'd like to revert to the Mortimer study and the lessons that we learned from the Mortimer study. As you remember, there were 11 monitored SUDEP cases in Mortimer's. One important observation was that the cardiopulmonary resuscitation was initiated late in all these cases, more than 13 minutes after the onset of the event. And in the additional 5 SUDEP cases, that were not under active monitoring at the time of the event, there was no resuscitation at all. In contrast, in the Mortimer study, there were 9 so-called near SUDEP patients, and these are patients that survive resuscitation after a cardiorespiratory arrest. These cases were different in that resuscitation was initiated earlier than in those cases that went on to a complete SUDEP. Within 3 minutes in all 7 for which this information was available. So these observations suggest that early intervention could be associated with a lower risk of SUDEP and a possibility to revert the event to a near SUDEP. And for that, close supervision is important, and this leads me to my conclusions. SUDEP is more common at night than during sleep, and nocturnal tonic-clonic seizures is a major SUDEP risk factor. Nocturnal SUDEP is associated with prone position. It's in the vast majority of cases unwitnessed, and thereby associated with missed opportunities for early interventions that could potentially revert the cardiorespiratory arrest and the impending SUDEP. And I think the data highlight the need for improved nighttime supervision of high-risk patients. And with that, I thank you very much for your attention.
Hello, everyone. Thank you for joining our session about the role of sleep in SUDEP. So what has basic science taught us about sleep and SUDEP? So basic science has taught us in preclinical animal models, preclinical SUDEP models, that we've identified biomarkers that precede sudden death. We've determined that sleep deficiency may promote these biomarkers. And we've determined that improving sleep may increase lifespan. And so really quickly, I want to review the importance of rhythms. So our body physiology, they follow rhythms. And many of these are circadian, and they run on a 24-hour clock. So the SCN is a region of the brain that is the master clock. And all of our peripheral clocks follow the master clock. And this allows for an increase in things like hormones and other things at certain times of the day, and a decrease at other times of the day. So there's no cogs like in a normal clock. These clocks run on the ebb and flow of proteins. So these rhythms run on the ebb and flow of proteins. So some proteins are increased during the day and they are decreased at night. Others are increased at night and they decrease during the day. So the most obvious behavior that these rhythms regulate is sleep. And in the brain, certain regions are more active when we're awake. So you can see here that in these select brain regions, these are the ones that are more active if they're in bold and less active when they're lightened out a little bit. Orexin is a neuropeptide that we'll talk about at the end of this talk, and this is awake promoting. So it checks to all of these other regions and wakes us up and allows us to stay awake and think during the day. And if we look at these same brain regions during sleep, during REM and non-REM, you'll see that some of these regions are more active during sleep and some of them are more active when we're awake. So this is during REM, and this is during non-REM. So here's regions that are more active during sleep, and these are regions that are more active when we're awake. So other things that are really important outside of sleep that these rhythms, these protein rhythms regulate are blood pressure hemodynamics, electrolytes, and neurohormonal systems. And so as you can see here, during sleep, blood pressure, heart rate, some things go down, other things are increased. And importantly, from midnight till 4 o'clock in the morning, our heart rate, our blood pressure, and our respiration all slow down. And this is mediated in part by an increase in parasympathetic drive. Now, what does this have to do with epilepsy and SUDEP? Well, there are 2 animal models, one epilepsy model, a pilocarpine-induced epilepsy model. So this is a mesial temporal lobe epilepsy model. And in the KCNA1 null mouse model, these animals have spontaneous recurrent seizures and they all die of sudden death. And in these 2 models, there's a reduction of some of these rhythmic proteins. And so their rhythms are actually attenuated. And so the first thing basic science tells us is that an attenuation of these rhythms may affect things like sleep, heart rate, respiration, blood gas stability, autonomic balance, cognition, and all of these are associated with sudden death. So the first thing basic science tells us is rhythms are important and we need to keep them in mind. The second thing basic science has taught us is that sleep is a risky time. So sleep is specifically a risky time for seizures. So during sleep, seizures can be more severe. So in a Dravet model of, there are more spontaneous spikes during non-REM sleep. And in a KCNA1 null model, the spontaneous seizures that occur during non-REM and REM sleep tend to be more severe. Now, in a wild type control animal, if you induce a seizure with a maximal convulsive shock during non-REM or REM sleep, those seizures also tend to be more severe when you compare it to when you induce it, the seizure when the animal's awake. Sleep is a risky time for seizure because at this time respiration slowed down. Again, with using that maximum convulsive shock model, if a seizure was induced during non-REM sleep, respiration was slowed even more. EEG suppression was longer and post-ictal apnea was also longer. So the second thing basic science has taught us is that sleep is a risky time for seizures. Now, all of this is assuming normal sleep. And I'd like to talk about something related, and that is sleep deficiency. So here, sleep deficiency outside of the field of epilepsy is associated with cardiorespiratory problems and early mortality. And so sleep deficiency is associated with cardiovascular problems and arrhythmias and bradycardia. It's associated with intermittent hypoxia, changes in breathing, apnea, and autonomic imbalance. And each of these independently are also associated with early mortality. And again, this is outside the field of epilepsy. So with our preclinical animal models, we can look at sleep deficiency and then also look at these biomarkers to see if they are evident in animal models of sudden unexpected death in epilepsy. And indeed, we did find that sleep deficiency occurs in 2 animal models, and these biomarkers were looked in one of those models, and all of these biomarkers were present. So how do we look at sleep deficiency in our animal models? So we can use actigraphy. So here we're just looking to see if the animals are active or restful. So if you look down here at the wild type control, you can see here the animal is more active and restful and active and restful. So if you look at this blue box, this is when the animals are restful. You can see that there's more sleep happening here. This is the epileptic, the KCNA1 null model, and you can see that the sleep is really disrupted. Another way of looking at sleep deficiency is with EEG. Here you can see in the control animals, they had experienced quite a bit of non-REM and REM, and this is highlighted by the blue box. And if you compare that to the KCNA1 null model, you can see they're awake a lot longer and they have significantly less non-REM and REM. So this has been found in both the SCNA1, the Dravet model, and in the KCNA1 null mouse model of sudden death. That there's an increase in sleep fragmentation. It takes longer for the animals to fall asleep. There's less non-REM, there's less REM, and there's less sleep spindles in the SCNA Dravet model. In addition, we found that if you look at sleep that happens right before sudden death in the KCNA1 null model where all of the animals die, there was about 2 weeks prior to sudden death, there was this increase in sleep deficiency, this cumulative increase in sleep deficiency. We also found that with this cumulative increase in sleep deficiency that happens about 2 weeks prior to death, that all of these biomarkers started rising around the same time. So these animals started experiencing things like intermittent bradycardia, chronic intermittent hypoxia, changes in breathing, an increase in apnea, and an autonomic imbalance. And both of these happened prior to sudden death. So the third thing basic science has taught us is that sleep deficiency occurs in 2 models of sudden death and is associated with these changes in these biomarkers that occur prior to sudden death, at least in the KCNA1 null model. The fourth thing basic science has taught us is that we can look at neurobiology to see if there's any brain regions that are associated with causing these sleep deficiency. So we can look at what cells and what brain regions. And I'll share with you 2 stories. One is looking at the thalamus. So the thalamus is GABA interneurons. These are inhibitory interneurons in the thalamus, in the RTN specifically. These guys are really, really important for sleep spindles and non-REM slow wave oscillations. And in the Dravet model, there's a reduction in the excitability of these guys. And so that reduces the sleep spindles and the slow wave oscillations. And so it's thought that dysfunction of these GABA neurons contribute to the sleep deficiency in Dravet. In the KCNA1 null model, we looked at orexin. Orexin is in the lateral hypothalamus. We learned that the really severe generalized tonic-clonic seizures propagate all the way down to the hypothalamus and to the lateral hypothalamus, as shown in these EEG traces. If you look at the top trace, that's the hypothalamus trace. And that there's an increase in the number of orexin neurons, and there's a 20% increase in the number of orexin neurons after animals have experienced generalized tonic-clonic seizures. And in addition, these neurons are more active. So the fourth thing sleep basic science has taught us is that disrupted neurobiology contributes to sleep deficiency in 2 animal models of sudden death. And the last thing I wanted to share with you is that treating sleep deficiency increases lifespan in preclinical animal models. And so here we found that improving sleep, here we've improved it in the KCNA1 null model. We found that improving sleep can stabilize these biomarkers and increase lifespan. So specifically, we blocked orexin signals with a drug that blocks the orexin receptors. Another treatment that we administered was in a separate cohort of animals is we gave a metabolic therapy, the ketogenic diet therapy. And we found with both of these treatments, many of these endpoints were stabilized and that lifespan was increased. Here is just showing that there's a 42% increase in lifespan after the ketogenic diet treatment. And the ketogenic diet was also looked at in the Dravet model, and lifespan was increased in that model as well. So a few other things that we know, there's been extensive studies of the serotonin system, and we know that there is an impairment in their ability to respond to hypercapnia, so their chemo response is attenuated. And this is in basic science studies and also in human SUDEP patients. We know in SIDS, both the norepinephrine and the cholinergic chemo response is attenuated in the locus coeruleus and the pontine, but we don't know if there's any problems with these in sudden unexpected death. So these are some new avenues of research that we can do in the future. And then there's lots of other brain areas that we can look at as well. So the impact on clinical care and practice is our basic science has taught us that there are biomarkers, sleep deficiency, intermittent bradycardia, intermittent chronic hypoxia, changes in breathing, an increase in apnea and autonomic imbalance, and all of these precede sudden death in the animal model. So these potential biomarkers are potentially can be monitored within subject to look for changes within subject. In addition, these maybe will also give rise to potential targets for treatment, specifically maybe treating sleep deficiency or treating these individual biomarkers, all with the hopes of increasing lifespan and preventing SUDEP. So after I gave a talk to PAME in 2018, I talked with several family members who had had loved ones who had passed away of SUDEP. And they told me that they noticed changes in their loved ones who had passed away, or that their loved ones who had passed away had noticed changes and had talked to them about it. And these changes were similar to the ones that we found in our basic science study. And so we created the survey to see whether or not other families also noticed changes. So our goal is to collect the data through the spring of 2021, analyze the data, present it to all of the SUDEP researchers and make this data available. And hopefully this will identify novel avenues for research in the future. Thank you very much for your attention, and I look forward to seeing you in the question and answer session.
Thank you both. Those are terrific presentations. Dr. Tomson, could you share with us what you talked to families about in terms of nocturnal supervision and families, individual patients versus their first generalized tonic-clonic seizure versus where the data is really good for those at highest risk?
This is a great and a very difficult question. I will start by saying that my strategy is very much similar to the one that Elizabeth shared with you in the beginning of this session, namely that I think it's important to bring the SUDEP issue up very early on in the epilepsy patient's career. So even if we at the beginning of the epilepsy history in an individual person, do not know much about risk factors, I always start just like Elizabeth. I would even be slightly different, because I will ask the question, what did you think when you saw your loved one have a seizure, rather than saying, do you think that this could be a fatal seizure? Because the answer is almost every time that I thought my loved one was going to die. And from that on, we can discuss the risk of SUDEP. At that stage, the message, even though it's correct, is more reassuring than scaring, because the expectations for a fatal outcome of a seizure is high in most relatives. So when I give the proper information, it's rather reassuring. But then the issue has been brought to the table, and we've created a platform for follow-up discussions at the time when we see if this is a patient that is going to develop characteristics of a high risk rather than a general risk of SUDEP. And it makes things much easier. The issue of nighttime supervision, I think, is extremely difficult. And it's for me as an adult neurologist, it's probably less common than it is for a pediatric neurologist. But it's a question for which I do not have a good answer.
Truth is, I don't think any of us really do. So, Dr. Simeone, just to extend from the world of basic science, and even put yourself in the shoes of someone who's had a seizure or a family member has, what do you think about recommendations in terms of wearable devices to control the quality of sleep to prevent SUDEP? Is there any information about the minimum time of restful sleep and how that could be increased behaviorally or with medications?
So yeah, I think these are fantastic questions. I think probably clinicians might be a little bit more appropriate to address these. As a basic scientist, I'm always very nervous to go into this arena of questioning. But I do know that in the sleep field, sleep hygiene and sleep deficiency is a public health crisis right now internationally. So it's not, only people that are at higher risk for certain conditions because of our new lifestyles. And so there's lots of different ways of increasing sleep hygiene. And so I would definitely strongly recommend people who, patients or families that have family members that have generalized tonic-clonic seizures, that they are just aware of what the sleep hygiene is in the individual that has epilepsy. The wearable devices, if I had, if one of my sons had epilepsy, I would absolutely have them wearing Fitbits at night, and I would be tracking their sleep. There's, lots of limitations with Fitbits, but I think overall it gives you a pretty good indication of sleep hygiene for an individual. I know it's really difficult. It's tricky because in clinic, most people, when they're in hospitals, they don't sleep really well. And so all of the sleep data that we do generate from clinic and in clinical studies that are obtained in hospitals, there's going to be that limitation where the patient isn't sleeping as well as they would when they were at home. And so I think a lot of information that we're finding out in clinics also needs to be understood with that significant limitation. I think future studies that monitor sleep in high-risk populations at home would be optimal.
Thank you very much. Thank you to both. The next portion of our session will explore a seizure-induced apnea as a SUDEP biomarker. Please join us in welcoming Drs. Nuria Lacuey and George Richerson.
Hi, thank you for the invitation to speak. My name is Nuria Lacuey. I'm an epileptologist, and I have a research interest in breathing dysfunction and SUDEP. Today, I'm going to be talking about seizure-induced apnea as a SUDEP biomarker. I have no disclosures. These are the learning objectives of my talk. One, to understand evidence of the phenomenology and basis of ictal central apnea and its role as a potential SUDEP biomarker. Two, to understand evidence of the phenomenology and basis of post-convulsive central apnea and its role as a potential SUDEP biomarker. And three, to understand the putative, structural, and functional basis of brainstem dysfunction in patients with epilepsy who may be at risk of SUDEP. No SUDEP talk seems to be complete without mentioning the mortality in epilepsy monitoring unit study. And this talk is no exception. This is the most comprehensive description of actual breathing dysfunction and SUDEP. As you can see in this figure, in all these cases, apnea in blue happened after the convulsive seizure, but it didn't happen immediately. Apnea was preceded or concurrent with bradycardia, and in most cases, the transient apnea in light blue, it was transformed into a terminal apnea in dark blue and death. In the Mortimus study, there was no comment made on ictal apnea, and in fact, apart from 1 near SUDEP, there has not been recorded death from ictal apnea. Therefore, we conclude from Mortimus that post-convulsive central apnea is probably the most dangerous form of apnea. In the next few slides, we will review not just post-convulsive central apnea, also ictal apnea, and what our current understanding of these two phenomena are. We studied 312 seizures in 126 patients in the EMU using multimodal polygraphy, including breathing monitoring. This was a multi-center study from the Center of SUDEP Research, and we were particularly interested in ictal central apnea. As you can see in this figure, this is the seizure onset. This here is the apnea onset, and you can see that the apnea lasted through the entire seizure, pretty much until the end, and it was associated with oxygen desaturation of 77%. ICA occurs in about 30 to 40% of seizures. We found that usually it's short, but there are some cases where actually it can be prolonged. As you can see in this red box here, these are patients with apnea duration longer than 60 seconds, and in these cases, it was associated with severe oxygen desaturation. We believe that this group here may be at risk of near SUDEP or SUDEP. And although such tests have not been directly observed, there is one near SUDEP with prolonged ICA of almost 5 minutes. And there is also another patient who had prolonged ICA in 2 seizures in the EMU and later died of SUDEP at home. PCCA, post-convulsive central apnea, it is a different phenomenon because it happens post-ictal, as discussed when I spoke about Mortimus. Through the Center of SUDEP Research, we were able to analyze 148 convulsive seizures in 87 patients. And as you can see here in this figure, this is a clinical seizure onset. And at this point, patient stopped breathing. This is an apnea, prolonged apnea with very shallow intermixed single breath. At the same time, brady and tachycardia and long periods of asystole. This combination of post-convulsive central apnea, bradycardia and asystole is in fact uncommon, as you will see. But first, I'd like to show you the video of this patient.
Cyanotic. a single measurement for you guys. Is it on? Is that good? So are your fingers relaxed yet? They didn't get back on it.
So we learned that PCCA occurs in up to a quarter of seizures and associated with bradycardia and asystole in only 6%. The relatively rarity of this combined phenomenon and the evidence from mortemus suggests that this may be a pre-mortem biomarker that we can identify in the EMU. In addition to the mortemus information, we found that PCCA usually lasts around 12 seconds, but it can last up to 85 seconds, and that was actually one of the near SUDEP patients. The mechanism behind ICA and PCCA are probably different, but the final pathway of breathing dysfunction is probably mediated by brainstem nuclei. We know that ICA is caused by a spread of seizure discharge to specific cortical structures. As you can see here in this figure, one has a stimulation of the amygdala induces clear apnea. On the other hand, PCCA is more likely to resemble a brainstem phenomenon because the cortex is in a post-ictal state at that point and therefore different from ictal cortex producing apnea. PCCA may be more likely to happen in the setting of underlying brainstem compromise, although the evidence is circumstantial. The evidence comes from post-mortem neuropathological studies showing the depletion of serotonergic neurons in specific areas in the brainstem, like the ventrolateral medulla. This is an important area for breathing control. Neuroimaging studies done in SUDEP patients also showed atrophy in similar regions. And more current studies done in the Center for SUDEP Research have shown that patients with low post-ictal serum serotonin levels are associated with increased incidence of PCCA. So basically, within brainstem damage may be one of the reasons why some patients have prolonged PCCA or prolonged ICA. So my concluding points have some impact on clinical care and practice, and they are: 1, prolonged ICA is a potential SUDEP biomarker. Brief ICA occurs in almost half of focal, usually temporal, of epileptic seizures. Prolonged ICA with profound oxygen desaturation may be dangerous. The mechanism of ictal central apnea generation is through seizure discharge in breathing cortical structures through brainstem pathways, and stopping the seizure may be the best way to terminate ICA, since it is an ictal phenomenon. 2, PCCA with bradycardia and asystole is a potential SUDEP biomarker. Brief PCCA occurs in almost a quarter of convulsive seizures, concurrent with bradycardia and asystole in only 6%, and that may lead to near SUDEP or SUDEP. And the mechanism of PCCA generation is likely brainstem dysfunction in regulatory nuclei. 3, PCCA with bradycardia and asystole can be seen pre-mortem and also terminally, suggesting this may be the more common mechanism of death. EMU evaluations that include breathing assessments may help identify risk. And for pre-mortem imaging studies of brainstem dysfunction require further study. Thank you very much for your attention.
Greetings, I'm George Richerson, and my task is to discuss the basic science aspects of this question of apnea as a SUDEP biomarker. I have no disclosures to declare. And here are my learning objectives. Now we know already that from other groups that terminal apnea is a cause of death in some SUDEP cases. This was shown particularly by the Mortimer study. We also know that many non-fatal seizures, about 1/3 of all seizures, result in both ictal or post-ictal apnea. So the question becomes, is periictal apnea really a useful biomarker of SUDEP risk? And I would argue that it is so common that it may not identify those at highest risk, just to know that people have apnea after a seizure. And we address the question of whether or not there might be a more refined measure of post-ictal respiratory dysfunction that is linked to the more closely linked to the pathophysiology of SUDEP. We tested the hypothesis. The response to hypercapnia is a sensitive biomarker for the risk of SUDEP. Now we know that high systemic CO2 normally increases ventilation and increases wakefulness. And those are both needed for recovery from post-ictal apnea and to prevent SUDEP, especially when a patient ends up face down in bed after a seizure. We previously showed that the CO2 response in epilepsy patients can be abnormal and may lead to an increased risk of SUDEP. For example, we reported an 8-year-old patient with Dravet syndrome who had CO2 retention to a level of 70 millimeters of mercury, which is quite high, for several hours after a seizure. And this patient, 3 years later, died of SUDEP. We also reported in a separate publication a 52-year-old man with focal epilepsy who had a very low slope of his hypercapnic ventilatory response, and he subsequently died 11 months later of SUDEP plus. This is data from that study showing that on the left, this is the response called the hypercapnic ventilatory response of an average patient in that study, in which the air is constantly rebreathed so that the CO2 level increases, and that leads to an increase in ventilation in a breath-to-breath manner. And we plot the slope of this curve to determine what the hypercapnic ventilatory response is. And this was the patient who died subsequently, showing that despite an increase in CO2 in his exhaled air, the ventilation basically remained constant the whole time. And this is a histogram of the patients in that study, with this arrow being the middle arrow, the right arrow being the median slope for all the individuals studied. And the left arrow is the patient that died, and he had one of the smallest slopes of any of the patients studied, suggesting that the hypercapnic ventilatory response may actually be a useful marker for the risk of SUDEP. Now, we subsequently discovered that the CO2 response is blunted post-ictally in some epilepsy patients. This unpublished data from Rup Sanju shows an individual patient, single patient, and their interictal hypercapnic ventilatory response, showing an increase in the slope of the CO2 response with increasing CO2. After a generalized tonic-clonic seizure, the response significantly decreased in slope. And we found this to be true in 4 seizures in 3 individual patients, with a significant drop in the CO2 response in going from interictal to post-ictal. We want to understand why this might be true, and in order to do that, we need animal models to study the mechanisms. We chose to use a Dravet syndrome mouse model, the mutation of SCN1A found in 3 unrelated patients, because this mouse model recapitulates a human disease with spontaneous seizures, seizures that are induced by hyperthermia, and seizure-induced death. And this is a survival curve for individual mice, or for a group of mice rather, 124 mice, showing that there is spontaneous death, and this was all due to SUDEP, seizure-induced death, leading to loss of about 45%, of about 55% of the mice over a period of 60 days. So this is a model we used, and had a talented graduate student in biomedical engineering, Yoo-Jung Kim, who developed this mouse epilepsy monitoring unit to allow all these different measurements to be made 24 hours a day, 7 days a week. And with the aid of Eduardo Bravo, a talented postdoc, they collected the data that has previously been published showing that these mice, these Dravet syndrome mice, died due to respiratory arrest after seizures. This is an example of a spontaneous death with a seizure occurring that leads to complete loss of all respiratory output. And this is due to central apnea. And then subsequently, there is a slowing and a decrease in amplitude of the EKG due to the hypoxia that develops from the lack of breathing. These traces at the bottom are just enlargements of the data from each of these time points. Subsequently, a graduate student in the lab, Frida Turan, discovered that the response to CO2 is impaired in these mice after seizures, just as I showed you in the human patients. And what she did was she increased the CO2 that mice were breathing from 0% to 7%. And that caused an increase in ventilation that was no different between wild type and Dravet syndrome mice. There's an increase in ventilation that occurred. She then heated the mice with a heat lamp to the point where the Dravet syndrome mice had a seizure, and she brought the wild type mice up to an equivalent level of body temperature. When she did that and then repeated the HCVR, what she found was that the wild type mouse, the slope of the HCVR did not change, but the slope of the Dravet syndrome mice did and decreased significantly to a lower level. This is just shown here in a different way of plotting it, with the slope of the ventilation before this, or interictally on the left, and then after seizures, postictally, the slope dropped significantly. So the question then becomes, why do seizures, or how do seizures cause blunting of the HCVR? We don't have the complete answer yet to this, but we know that seizures project to the brainstem via the amygdala. This was shown by Brian Deloe in 2 different papers in epilepsy patients, both adults and children, showing that apnea coincides with seizure activation of the amygdala, and that stimulation of the amygdala with electrical current induces apnea. Eduardo and Frida subsequently have shown that the same thing occurs in the Dravet syndrome mice, and that the abstracts for these studies are here at this meeting with first authors Bravo and Turan. What they've shown is apnea coincides with seizure activation of the amygdala, that electrical stimulation of the amygdala induces apnea, and they've taken it a step further by showing that amygdala lesions decrease apnea and death induced by heat and spontaneously with spontaneous seizures. So interrupting the pathway to the brainstem prevents death. And the target we don't completely know yet, but one target that we know may be involved is serotonin neurons of the medulla. In a study in collaboration with Hal Blumenfeld, we show that seizures induced by hippocampal stimulation in rats inhibit serotonin neurons. And this is important and relevant because serotonin neurons are central respiratory CO2 chemoreceptors. These neurons, shown in green here, are located next to the large arteries in the medulla, shown in red, on the ventral surface, in the midline. And when you raise CO2 levels, these neurons increase their firing rate due to a change in intracellular pH, shown here. So how does this impact clinical care and practice? Well, first of all, respiratory monitoring should be standard procedure in all EMUs for safety purposes. And central apnea may be a common mechanism of SUDEP. And we believe that the HCVR, which can be performed easily at bedside, may be a biomarker for high risk of SUDEP. In fact, a blunted HCVR may be a surrogate of defective serotonin neuron function when they are inhibited by seizures. And prevention of SUDEP might be most effective if we target these underlying mechanisms. I'd like to thank the people that did this work, especially Yijun Kim, Frida Turan, Ruth Saint-Ju, and Eduardo Bravo, and we thank J.C. Wagnon and Marianne Meisler for generating the MySTORY study. Thank you very much.
Thank you, George and Nuria. I just wanted to mention, and this was pointed out by someone who's listening in, that for those people living with epilepsy and their families, seeing the videos that we saw just now and really throughout the conference, understandably are very could be very disturbing, and really should think about talking to someone about it if upset, or particularly your healthcare provider. So with that, we have a question. Have any adult studies been performed evaluating positive airway pressure modalities and its effect on SUDEP? That is, does an adult with epilepsy and sleep apnea, obstructive or central, which is effectively treated with positive airway pressure or hypoglossal stimulation, have a lower incidence of SUDEP compared to patients with sleep apnea that are untreated, or epilepsy patients without OSA, obstructive sleep apnea?
I think it's a great question, and it's very exciting that now we are actually talking about preventive strategies, when 10 years ago we didn't even know what was producing SUDEP. So that's very exciting. There are no studies using positive airway pressure to prevent apnea. It could be an option for somebody who has very prominent repetitive PCCA, but it will be unlikely that actually the CPAP stays in place after the seizure. Remember that these patients usually die after a big convulsion, so that will be unlikely. And also, we don't know how effective to treat central apnea as opposed to obstructive apnea. And patient will have to wear this every night. So currently what we are trying to do is, in our lab, is to use stimulation techniques, brain stimulation techniques, to see if we can actually enhance breathing and eventually use neuromodulation techniques with closed loop stimulation, where we can actually detect this apnea and treat it. Something that we also are investigating is the role of serotonin in this, and see if we can actually use serotonin agonists, SRIs, to prevent this apnea. So we've been seeing that after generalized convulsive seizures, patients with higher level of serotonin, they have less PCCA. And also in patients taking chronically SRIs, it seems that they have less frequent of ICA, half incidence of ICA. So we believe that there may be also a role for the SRIs although we need trials, we need randomized controlled studies to confirm that.
Great, thank you. Dr. Richardson, how practical is doing HCVR by the bedside?
It's quite easy to do. It takes about maybe 3 or 4 minutes. It's well tolerated. Most patients, it doesn't bother them. Occasionally some people get short of breath or a little anxious with it, but most people, it's really tolerated very well. And it's probably likely that this could, the reason we did this in patients initially was to compare it to what we find in the EMU, but the idea is to transfer it to the outpatient clinic. If it turns out to be a useful biomarker, then it can be done in a patient in clinic quite easily.
Thank you. In the minute remaining, we have a very interesting question. I've heard folks say that epilepsy surgery will prevent SUDEP. I've also heard folks say that palliative surgery is better than curative surgery. When we expect surgery to be palliative without complete control of GTCs, is that still good enough? Meaning, even if surgery is palliative, is it better than no surgery at all?
Yeah, my answer would be that if anything that reduces seizures reduces the risk of SUDEP, but as long as you have some seizures, then the risk would still be there.
Great. Thank you both very much. It's now my pleasure to introduce Sally Schaefer and Dr. Lori Isom, who will give us an update on a recently occurring SUDEP summit.
Thank you so much, Jeff. My name is Sally Schaefer, and I'm the director of the SUDEP Institute. And I am also pleased to be here with Dr. Lori Isom. Next slide, please. We have nothing to disclose today. What we want to share with you a little bit about is the SUDEP Coalition Summit. You have heard a lot of the research and work being done, and in addition to that, the SUDEP Institute with the Epilepsy Foundation developed, initiated, and convened, starting in 2019, a coalition summit. And what this means is that we wanted to develop an action plan to advance our understanding of SUDEP. How can we develop some risk assessment tools, improve awareness and accurate counting of SUDEP cases? You heard Dan talk about the medical examiners and coroners earlier, and ultimately end SUDEP in 5 years. When I was hired, the goal is that I'm out of a job, and I want to be out of a job because I too lost my daughter, and I don't want anyone else to be in these shoes. The coalition was comprised of 50 participants with individuals from all different disciplines in and out of the SUDEP space from around the world. It was simply amazing. And when we reached out and asked for everyone if they would like to be part of this summit, we heard back from people within 24 to 48 hours. And this was all volunteer based, and everyone came on their own free will of wanting to participate. We had amazing co-chairs in Dr. Lori Isom, who you'll hear from her next, as well as Dr. Dan Friedman. We also had a wonderful organizing committee with many of the people that you've heard from today. I won't list all of their names, but we so appreciate everyone's involvement in keeping the process going. Our first meeting, we started meeting in groups in January of 2020, and our first large meeting with all of the groups was held in June. And we talked about the recommendations, and then in September, at the end of September, we met to finalize those recommendations. Next slide, please. So when I talked about the groups met, with all the 50 individuals that we had as part of this, over 50 people, we had 4 different work groups that started meeting in January 2020 on a monthly basis. We had an awareness and behavior group. I won't name all the individuals in these groups. We also had a basic science, a clinical science, and we had a public health and epidemiology. And each group came up with their recommendations, in which we talked about and finalized in September. I also want to share, beyond the organizing committee, I had wonderful help from folks in the Epilepsy Foundation, Dr. Sonia Demanis, Allison Kukla, Liz Schreiber, wonderful people who organized all of these meetings, these monthly groups, and the large meetings as well. I'm now going to turn this over to Dr. Lori Isom, and she's going to share the next 2 slides.
Thanks, Sally, and hello, everyone. I'd like to first take this opportunity to thank Sally Schaefer for her tireless work to end SUDEP. This summit was Sally's brainchild, and her energy throughout was really infectious. And because of her, we were undaunted by the pandemic, and we just switched to virtual meetings, and I think we got a lot done. I was also honored to serve with Dan Friedman to lead this important initiative. So each of our working groups has a comprehensive plan that we've written that can be shared with those of you who are interested, but here is a summary. So our awareness and behavioral group decided that the most important next steps are to improve awareness of SUDEP among people with epilepsy and equip them with strategies to mitigate risk, and to increase provider knowledge of SUDEP and give them the skills to assess, communicate, and mitigate risk. And I think we heard a lot about that from our parents this morning. The Clinical Action Committee decided the most important steps are to build infrastructure for running SUDEP trials, to utilize SUDEP detection devices more in the clinic for SUDEP prevention, and to leverage electronic health records to guide clinician actions around SUDEP risk mitigation. The basic science group decided that our immediate goals are to create tools to allow researchers to better capture the SUDEP animal landscape and to align SUDEP models with clinical experience. And our ultimate goals are to combine 1 and 2 to ultimately understand the mechanism of why this seizure, why today? Why not yesterday? Why not a previous seizure? What's the perfect storm that results in SUDEP? And then our epidemiology and public health colleagues decided that the most important next steps are to improve SUDEP counting and to develop and identify the best SUDEP risk screening tools for clinical studies and clinical practice, and to further SUDEP intervention. So you can see that there is a lot of synergy between all of these groups. And each group identified in their comprehensive plan metrics and measurable outcomes for the future. Next slide. So the future is bright based on these recommendations, and we're undaunted at going forward. So the effort to complete and implement the recommendations will be coalition-led. So we are seeking volunteer organizations and other scientists and clinicians and parent advocacy groups to help us move forward. And our first advocates that came forward for us for the Child Neurology Foundation, they've already agreed to lead the partnership for implementation of the awareness and behavioral recommendations. So it's important for us now to identify new and establish funding partnerships to move all of these recommendations forward. There are some low-hanging fruit, so to speak, that can start immediately, and that this work has already started. And that really includes the awareness and education pieces of the last slide that I talked about. But going forward with especially the basic science group, developing new and more important animal models, and then correlating all these data with translational work is going to be an important next step that will take quite a bit of funding. Many of us are involved with the NINDS epilepsy benchmarks effort, and we'll be working through the Curing the Epilepsy conference in January to make a lot of this happen. So again, I'd like to thank everyone, and we're ready to take questions.
Hey, thanks, Lori and Sally. Just to get the conversation going, could you talk about why the SUDEP Summit? Why did it take place? What were the motivations?
I can cover that if you'd like, Lori. When I was interviewing for this job almost 3 years ago, I had heard about the research being done worldwide, and I really, the Centers Without Walls, I knew the funding for that would be ending. And what I really thought about is how can we keep these conversations going between many disciplines, individuals in and out of the SUDEP space. For instance, SIDS, how did that become this nationwide campaign? How can we get there? How can we make sure everybody knows about SUDEP that has epilepsy? And so that was kind of the premise behind my brainchild when I was interviewing of, we need to keep this going, but we need everyone to come together and really end this, and putting that time frame of 5 years, and that's our goal. But that is really why I thought of this when I was interviewing for this role, is to bring everyone together and continue these conversations.
It seems like so many of these efforts are focused on continued funding, which obviously is essential. How can people lobby in a very direct way for more funding?
I think that it's important, as I mentioned, for those of us who are in the epilepsy field and are funded by NINDS and are working closely with those program officers to work with them as they establish the new strategic plan for funding for neurological disease going through the next 5 years. So I think that's a very important step. Another important step is that the Department of Defense funds some very important disease initiatives, and that's something that we can work with Congress on to increase funding for epilepsy. As what was mentioned earlier today, knowledge is power. And I think that the more advocacy we have from our parents, our parent groups, the patient groups, and then our researchers together through the Centers Without Walls and other mechanisms, we can make this pitch known and be successful.
There are a lot of different people listening in, and some of the question is, if someone wanted to contribute to the effort in terms of having input to the SUDEP Summit, what would that look like?
Yeah, please contact any one of us. Contact me, contact Dan Friedman, contact Sally. We would love to include you in one of our working groups. If you have an idea for another working group that we didn't think of, let us know, because we can form that and go forward. So this effort did not stop with our last meeting in September. It's ongoing.
Terrific. And could you comment on similar efforts outside of North America to move the SUDEP cause forward?
There are a number of advocacy groups, patient groups in Europe and Asia. For example, our partners in the Dravet Foundation in Spain and France and Asia that are working together. And in fact, Dravet Spain funded an important new animal model for Dravet syndrome that we're working on that is now freely available to researchers. So I think that partnering with our advocates in countries besides the United States is really important, and Canada as well. I'm looking at my colleagues on our panel.
Yeah, I mean, I think this is, it's an important point to be made, particularly with Dan Friedman's talk about social determinants of health, is that SUDEP certainly occurs in many countries with less resources, and that we should always be cognizant of including those in all of our discussions. So thank you very much.
And they were, Jeff, we had many advocacy groups in North America and beyond as part of our discussions. And I know we had individuals from the UK where we learned so much from them and the work that they've been doing already. So I was pleased to have so many different groups on and part of it.
That's great.
If I could just add, I have a colleague who trained in my laboratory who is now a professor of pharmacology in Ghana. And she's working on novel therapeutics using natural products there. And so the more outreach we can have, especially with Africa, is really, really important.
Speaking of Africa, I know that our next speaker, Gardner Lapham, is involved in involving Africa in the international epilepsy effort. So with that, I'd like to introduce my colleague, friend, Gardner Lapham.
Thanks, Jeff. Hi. This was awesome. I am just thrilled that we achieved so much in 2 hours here. As just Jeff said, I'm Gardner Lapham, and I have the honor of helping to bring this powerful session to a close. As Tom shared in his opening remarks, PAME's goal is to bring different stakeholders together to learn from one another and to inspire deeper action. And I think this is what we've done today. So thank you, speakers, for your thoughtful presentations. Many thanks to everyone for making time to be part of this unique collaboration. Like Libby and Victor, I fell into this world of SUDEP after losing my vibrant and healthy 4-year-old son. Henry died nearly 13 years ago, which is really kind of hard to believe. And at the time, you know, SUDEP was rarely discussed when there was only minimal research activity and when there was not much of a community working together to untangle the mystery of SUDEP or that of overall epilepsy mortality. Thankfully, amazing strides have been made, and PAME has played a role in forging this change. PAME embraces the power of education and the spirit of welcoming different stakeholders. I know that PAME has been a home of sorts for me, a place where my loss is understood and where I feel part of a shared quest. This is why I'm excited to announce, next slide, please. I'm excited to announce that PAME and the partners that drive the collaboration see opportunity in expanding PAME's educational offerings. Next year, we will roll out 6 webinars that dig deeper into some of the topics we discussed today, as well as other topics that have been identified as pressing or new. Here's a preliminary list of webinars. If you have any ideas for sessions or want to be involved, please reach out. The first one will kick off in February. So here they are. And again, these are just preliminary, but finding the right words, a dialogue between families and providers, how to study mortality, new ideas to advance epidemiological understanding. What can we learn from the basic science of other sudden deaths? What are the social determinants of all causes of epilepsy mortality? Grief work, how do we find a way through loss? And then SUDEP Action Day is sort of a placeholder, but all these are works in progress, so please reach out. Last slide, please. So please visit the PAME website for more information. Session recordings and updates will be there. I just want to thank you again for joining today. We hope you'll continue to participate next year in the webinar series, as well as the hopefully in-person PAME meeting in December. Please contact us if you're interested in becoming more involved in planning efforts. We'd love to bring new partners on board and deepen engagement with existing partners. Please visit the website as I mentioned. But now let me just turn it over to Jeff one more time and let you wrap it up.
Yeah. And so just to say thanks to all the speakers and to everyone who participated and joined us in this virtual PAME in 2020. We look forward to all the events that Gardner described. Please check out the PAME website for the PAME-related or SUDEP-related abstracts that are at AES this year. There's also a poster tour that Elizabeth Donner and George Richerson will be leading in an hour or so, I think. Please check that out. And finally, just to thank Anne Gramiak, who's the person from AES that really put this all together for us. So everybody, thanks and have a great meeting.
Thank you.